Decreasing life expectancy and declining fertility rates mean that the world is getting older. Facing this situation and the challenges that come with it, how can we find solutions that make a real difference in the lives of the elderly, especially in countries that are aging rapidly, like Singapore? Moderated by Hui Cai, Vice President and Head of Content at WuXi AppTec, our guest speaker, Benjamin Seet, Deputy Group CEO at National Healthcare Group, shares Singapore's experience and gives us a glimpse into the future of healthy aging.
Thank you everyone for joining us today. I'm Hui Cai, Vice President and Head of Content Division at WuXi AppTec. Today, October 1st, marks the International Day of the Older Persons. And today we're launching Dialogues on Healthy Aging to celebrate not only this special occasion, but also pledge support of the United Nations Decade of Healthy Aging 2021 to 2030, a global initiative to improve the lives of the elderly, the families, and the communities. And join me today is Professor Benjamin Seet, Deputy Group CEO and Group Chief Research Officer at Singapore's National Healthcare Group, an organization that supports more than 1/3 of Singapore's population. Ben is an extraordinary public service leader with over 20 years of military service experience, served as a Chief Medical Officer for the United Nations peacekeeping operations in New York. And most recently, he was the Executive Director of Biomedical Research Council at A*STAR, Singapore's national agency for science, technology, and research. Ben, it's my great honor to have you with me today.
Right. Thank you for having me.
I want to start with the state of aging in Singapore. According to the United Nations, Singapore will be rising to become a super aging society, I believe, by the year 2026. So can you describe to our audience today, what is the state of aging? What are the unique challenges Singapore is facing in terms of healthy aging in this topic?
Okay, so Singapore is one of the fastest aging countries globally. And I think if you look specifically at the National Healthcare Group, the hospitals that we run are actually sited in the central part of Singapore, which are the oldest precincts in Singapore. So in a sense, our hospitals have to deal with the oldest parts of one of the fastest aging countries globally. And in a sense, I think that actually provides a mirror as to where the rest of Singapore and maybe where the rest of Asia will land in a few years' time. So we see ourselves as a experimental ground, as well as a real-world evidence area for looking at what the future of healthcare for the aged would look like anywhere in the world. And I think just to look at some of the statistics, it is actually quite scary. When you look at the patients in our key hospital, Tan Tock Seng Hospital, 2/3 of the patients are more than 65 years old. And when you look at how much healthcare resources they spend, 20% of our patients actually consume 85% of healthcare costs. And a very small 5% of our patients consume 57% of our healthcare costs. And most of these people are old people with multiple medical problems. They may come in for medical emergency. They may come in for deterioration with their chronic diseases. But I think it provides a very huge burden of disease that will continue to grow as the patients age further. So that's in our locality, the National Healthcare Group.
So how are you preparing right now? How is Singapore adapting to this new reality?
Okay, so I think when you look at it, quite a lot has to change. As it is, we already have a very efficient healthcare system. I think we spend relatively a smaller percentage of our GDP on healthcare compared to most other developed countries. But at the same time, I think this healthcare, we are actually reviewing whether there are better ways to manage healthcare for large populations. The focus in the past has always been treating sick patients in an acute hospital. So we treat end-stage disease, we treat late-stage disease when they create problems and complications that bring the patient to an acute hospital. But I think a lot more really needs to be done in health promotion, in preventive medicine. More has to be done in primary care facilities because we can't keep building more and more expensive hospitals. But we will need to redistribute healthcare such that the majority of care is provided in the community, in primary healthcare facilities, as early as possible to delay or to ultimately prevent people from going into the hospital. So take a very common condition like diabetes. I think we've seen studies from different parts of the world in the UK and China, where a large number of people with very early diabetes with the right interventions can actually be treated. So you have reversal of early diabetes. And we believe that between 1/3 to half of early diabetics can actually have interventions to reverse that diabetes such that they don't end up having to deal with a lifetime of diabetic therapy, diabetes therapy, or to deal with complications of diabetes. And even if we are not able to prevent or to reverse this diabetes, I think we can at least work a lot more to prevent the complications of diabetes, whether it's retinopathy, renal disease, heart disease, the increased risk of strokes. So I think a lot more can be done to prevent rather than to treat in acute care hospitals. And I think when you look at it, there are probably three things that we are doing in a very big way now. One is to push our healthcare system from institutional care into integrated care. And by integrated care, I mean providing healthcare on a geographical basis. So it's an acute hospital working with a network of primary healthcare clinics. It could be general practitioners, it could be government polyclinics, as well as with community organizations to try to provide healthcare as a network rather than as individual institutions. And in that process, redistribute some of the care for chronic patients, for early disease to community practitioners. So that's one, and integrated care. And I think one of the things we are also exploring at the national level is to look at how we can review the healthcare reimbursement process in Singapore to one that incentivizes primary healthcare and prevention of disease. And the third thing is the whole area of health education, patient education, I think really needs to be improved. Medical literacy is very low in Singapore for the older populations. And I think this is probably the case in many Asian societies where most of the knowledge rests with the healthcare practitioners and the individual actually has very little awareness or understanding of his disease. That needs to change. So we're in the age of precision medicine. I think we need to move into precision health promotion, precision medical education to provide very targeted, very personalized medical advice for each individual and to be able to better measure the outcomes at the individual level. So to sum up what I've just said, it's quite a bit, but I guess it's first of all, looking at providing integrated care rather than institutional care. Secondly, reviewing how healthcare reimbursement can be done to actually incentivize early treatment rather than late stage treatment. And thirdly, improving medical literacy and health education, more precise, more targeted health education so that that's more effective.
Great. Just to continue on the education topic, your role at the National Healthcare Group is education and research. So can you share with our audience here a couple of examples where you focus on the targeted and precision education, especially around the elderly? Is there any programs you'd like to share?
So if I were to draw on what I'm doing in COVID-19, I think there are some parallels. Because if in the past year and a half, I think what has happened is that the entire world has actually leveled up substantially in terms of their knowledge of COVID-19. And specifically in the area of vaccines, I think the level of medical literacy and the influence on personal choice has probably reached a level that no other medication has in the history of medicine. I think every person on the street would have a view whether they want a particular vaccine, whether it's an mRNA vaccine, an inactivated virus vaccine. And I think this is a level of literacy that has never been achieved for any other condition or disease. And it shows that once there is the will to learn something, once there's enough publicity, we can actually bring medical literacy to a level where people can actually make very informed choices as to which vaccine they want to receive, or about complications of the disease, or other views about transmission of the disease. So I think COVID-19 has shown us that people can, if they're interested enough, pick up enough medical information to make important decisions. The challenge, I guess, is that there is also a lot of information that's not accurate, as well as information that is wrong, because so much of this is in social media. But it points to the fact that if we can provide accurate, reliable information to the people who are interested in receiving it, we can actually change our practices. So that's for COVID-19. But I think specific to diseases in aging, I think it's a bit more of a challenge because when you look at the aged, many do not suffer from just one disease. So if someone has diabetes in Singapore, it's likely that he or she will also have obesity, might have hypertension, possibly a heart disease, may have had a stroke. And someone in such a condition would also face mental health problems like depression. So the typical aged person is not a single, doesn't have a single disease that's managed by a single doctor, but could have multiple medical problems. It brings forth the problem of polypharmacy as well, that rather than to take just one set of pills a day, a person might end up having to take 10 different pills, 15 pills, and that's not uncommon for the elderly. So the challenge, I guess, is how do we look at an individual with multiple medical problems and manage the motivation to look after himself or herself, because it is challenging to take so many pills. If you have associated depression, if there's frailty and there's difficulty moving around, I think it presents a lot of challenges. And I think, again, that that's another driver for reviewing the healthcare system. Because if care is provided in an acute hospital for this individual, he or she will be seeing different specialists in different departments on different days. Whereas if we move that care to the polyclinic, perhaps a non-specialist, but a well-trained non-specialist can actually manage the patient as a whole. And that includes not just the treatment, but the monitoring, as well as the education. And that person, I think, hopefully should be able to spend more time with the patient than a busy physician in the hospital, and therefore play a bigger role in patient education and dealing with motivation, because that's extremely important to ensure compliance to treatment.
Yeah, absolutely. COVID definitely highlights the importance and the need to take good care of the elderly. And during the COVID, the whole pandemic, our elderly has been really the most devastatingly impacted, that's for sure. And looks like there's a lot of lessons for us to learn from the COVID. But as you mentioned, aging is a lot more sophisticated and complicated than the COVID situation. So let's move to the research side. You are the Chief Research Officer for the National Healthcare Group. And what are really keep you up at night, especially when it comes to the impact of research on the healthy aging frontier.
Okay. So I think when you look at research in aging, it's a little bit more challenging than research in, let's say, oncology or cardiovascular disease, because it cuts across many disciplines. So if you ask me what are the key problems in aging, I mentioned one earlier, it's multimorbidity. So it's a person that has got multiple medical problems. It could be metabolic, it could be vascular, it could be mental, it could be physical. So the ability to do effective research that cuts across many disciplines is not easy because it's not going to be done by any one department, but you need to bring people from different departments and across different disciplines together. So multimorbidity is probably one of the biggest challenges in research in the aging. Two other areas of priority would be frailty. And with frailty, I'm talking about physical frailty. So this is weak muscles, weak bones, weak joints, and the tendency to fall down. And if an elderly person has osteoporosis, that fall could actually lead to a pathologic fracture. So in a sense, I think frailty research is also very important. But frailty is also another problem that doesn't have a department owning it in any hospital. There's no department of frailty. The orthopedic surgeons will see some of it. The geriatricians may see some of it. Endocrinologists may see some of it. And the treatment could be provided by a physiotherapist and occupational therapist. A nutritionist may have a role. But at the end of the day, I think it's another complex multidisciplinary problem. But frailty is extremely important to deal with as early as possible. And I think what we are trying to do in our research is to keep an aging person as mobile as possible for as long as possible. If someone is active and elderly, does exercise, goes out all the time, it's not only good for musculoskeletal health, it's also good for metabolic health. It's good for vascular health. You are able to exercise, you're able to walk around rather than sitting in a chair at home or lying in a bed at home. It's good for mental health as well. Because someone who's at home all the time and doesn't go out, it's more likely to suffer from depression. So in a sense, if you see that frailty and the ability to be mobile will not only prevent falls, but actually leads to better medical health as well as physical and mental health. So I think that's another big area of research for us. And the third area is actually in mental health in the elderly. Again, this is probably very poorly understood, probably underestimated, and definitely undertreated in most societies. I'm quite sure in Singapore as well. Because someone who is elderly and at home, like I described earlier, if that person is frail and unable to move out, very high chance to have depression. If someone has end-stage organ disease, whether it's retinopathy affecting vision, whether it's a renal disease requiring dialysis, whether it's even diabetes that requires regular medication, hypertension requiring a long-term medication, I think many of these are associated with depression. And it's our ability to, how do we manage depression of old people at home? And I think this is where the technology, through digital technologies, might provide access to these people in their homes on a daily basis through digital technology, wearables, sensors, telehealth, whereas in the past, they would probably see a doctor every 3 months or every 6 months for a very short interview. So when we look at the research directions that we are taking, to sum up, firstly, to look at metabolic health and multimorbidity in the elderly. Secondly, to look at frailty with a focus on maintaining mobility and preventing falls. And thirdly, at improving the mental health of the elderly, particularly those with chronic diseases, and primarily using digital technologies as a tool and platform to be able to access that.
Great. Now let's take a look into the future, right? 2021 marks the beginning of the United Nations, the 10-year initiative on healthy aging, as the whole world coming together to tackle this, the new reality. My question for you is, 10 years can be actually quite short a period of time. What do you see that could potentially define success of this 10-year initiative? What are the key important, maybe inflection point that we may observe down the road as we look into the next 10 years?
So when you look at aging societies, 10 years is actually a very short time. Even when we look back at the millennial goals that were set by the WHO and the UN in 2000, very ambitious goals that cut across different aspects of society and health. While there were major milestones, it is actually very extremely difficult to be able to implement major health and policy changes across every country in the world. So I'm talking about health services research, population health, behavioral research in health. I think that's extremely important because how people look after themselves or don't look after themselves depends a lot on their health motivations, their health behaviors, their medical literacy. So I say shift some of the funding for the good work that's done in oncology, in cardiovascular, and eye disease, to public health research, to health education research, to health outcomes research. Because traditionally, those areas are the most important, but the least funded. So I think that's probably an important shift that I want to see. More funding shifting to downstream rather than upstream research. And I mentioned that a little bit earlier. I think health education is key. So I would focus a lot more on developing very targeted, stratified. I'll probably use the word stratified. We need to stratify health education according to different risk factors. It could be demographic. So take Singapore. How I would provide health education for the Chinese, the Malays, and the Indians in Singapore would be quite different because they look at disease from different cultural contexts, sometimes different religious contexts. I would stratify education based on education level. So for someone who is better able to grasp scientific facts, we should provide a lot more information so they can take an evidence-based approach. For people who are not so well equipped to deal with lots of data and statistics, again, to be able to simplify very cogent messages such that they can actually have an impact on that. So I'd say that this is an area that needs a lot more development, and it needs to be very precise. I've used the word a few times, precision health promotion, precision health education. I think that is extremely important. And the third area which I think could be very impactful in a very quick way would be digital health. So the ability to tap onto wearables, sensors, mobile devices, big data analytics to be able to better understand a patient's medical condition, particularly if we can monitor him or her at home. I think there are a lot of promises, a lot of possibilities. So I'll see definitely a lot of growth in the area of digital health, largely driven by big companies as well as app makers. So big and small companies will be able to contribute to building this space. But I guess at the end of the day, trying to sift through the huge volume, the large number of apps and devices in this space will obviously be a challenge that we have to address.
Absolutely.
So again, to sum up this part, I think first of all, a shift of research funding from acute care, from specialized care to primary healthcare and health promotion. Secondly, a greater emphasis on health education research and understanding patient behaviors and motivations to design better interventions. And thirdly, the ability to leverage on technology, particularly digital technology, to be able to monitor patients in their home and to be able to intervene earlier if there are changes from the baseline.
So speaking of, actually, we're almost running out of time now, but I want to really capture what you just talked about, the digital technology, the potential that's very exciting for us all. and you're talking about the monitoring at home. So how would that change the hospital care? So if I were to ask you a final question about how do you see the 2030 hospital care or healthcare may look like compared to today with all the technology, can you give us some picture about that?
Okay, how do I paint a hospital in 2030? I think less patients will go to the hospital for their chronic diseases. Some will be treated at home. Some will be treated in a community care facility closer to their homes. Part of that treatment or part of the disease monitoring will be done by remote devices, something that they wear which monitors their vital parameters. Hopefully some point in time, a very sensitive sugar monitor. Their activities, physical activities, sleep patterns, exercise will be monitored remotely, so that by the time this patient goes to a clinic, the doctor will have a summary report that sums up the entire picture of a patient's health over the past 3 months or 6 months, rather than to have just a single point in time, which is what's happening today. That if you see a patient every 3 months or 6 months, that's all the doctor gets to see. So I think digital technology will allow continuous longitudinal monitoring. It will allow timely interventions if there are changes from the baseline. It will allow the healthcare practitioner to have an overview of the cumulative health of a patient over the past 3-6 months, rather than at a single time point. And I think that will actually change how care will be provided.
Yeah, that's very exciting. Thank you so very much. Definitely, that's a future we all very much look forward to. I just want to, as we close today's interview, I just want to thank you, Ben, for providing such wonderful insights. And this is a very big topic, and I'm sure it will take many, many more rounds of dialogues like this for us to really see the future and change the future, and definitely embrace the future to improve the lives of the elderly, the families and patients, and the communities. Thank you, Ben, for the wonderful work and efforts you've put together behind the initiative. Hopefully, we have more and future opportunities to welcome you back to our program and discuss more and share the progress you have made in the Singapore front. Thank you so very much, Ben.
Thank you very much. And again, thank you for having me today.